2. In this presentation, we are going to discuss hematologic and lymphatic disorders. Now let's review interventions for patients who are at high risk for infection. These patients include those who are immunocompromised, receiving chemotherapy, or recovering from major surgery. Our role as nurses is to reduce exposure to harmful microorganisms and act quickly if signs of infection appear. First, whenever possible, place the patient in a private room to limit exposure to others. Hand hygiene is absolutely critical. Staff, visitors, the patient, and even family members must all wash their hands before entering the room, before eating, after using the toilet, and before touching one another. Visitors or staff who have any signs of illness should not enter the room. Patients should be instructed not to handle flowers or plants because soil and stagnant water can harbor bacteria and mold. They should also avoid unwashed fruits and vegetables, which may carry harmful microbes. To prevent infection, we should minimize the use of indwelling catheters and other invasive devices. If invasive procedures are necessary, nurses must use strict aseptic technique. When fever develops, acetaminophen is the safest choice for antiparesis because aspirin increases bleeding risk, especially in immunocompromised or post-surgical patients. Finally, any increase in temperature must be reported immediately, as it could be the first sign of infection. These measures are part of a concept known as protective or reverse isolation, where the goal is not to protect others from the patient, but rather to protect the vulnerable patient from outside germs. Anemia is one of the most common blood disorders we will see in clinical practice. It is defined as a deficiency in either red blood cells, hemoglobin, or both. Because hemoglobin is responsible for carrying oxygen, anemia leads to a reduced ability of the blood to transport oxygen to body tissues. This results in symptoms like fatigue, pallor, shortness of breath, and dizziness. Let's look at the causes, or etiology, of anemia. Nutritional deficiencies are a major cause. If the body lacks iron, it can't make enough healthy hemoglobin, leading to microcytic anemia. On the other hand, if the body lacks folic acid or vitamin B12, red blood cells become larger than normal but are not functional. This is called macrocytic anemia. A special type of vitamin B12 deficiency is pernicious anemia, where the problem isn't lack of intake but lack of intrinsic factor in the stomach, which is necessary to absorb B12. Now let's review the pathophysiology, or how anemia affects the body. Anemia can result from impaired production of red blood cells, such as in aplastic anemia, where the bone marrow fails to produce cells, or from nutritional deficiencies. It can also result from increased destruction of red blood cells, as in hemolytic anemia or sickle cell anemia, both of which shorten the lifespan of red blood cells. Another cause is massive or chronic blood loss, which can happen with trauma, heavy menstrual bleeding, or gastrointestinal bleeding. Finally, certain genetic conditions can impair the structure or function of red blood cells, leading to inherited forms of anemia. As LPNs, it's important to recognize the underlying cause of anemia because that will guide treatment, whether the patient needs supplements like iron or folic acid, medications like vitamin B12 injections, or blood transfusions in severe cases. Anemia does not look the same in every patient. It depends on how low the hemoglobin is and how quickly it drops. The table here breaks symptoms into mild, moderate, and severe anemia. With mild anemia, hemoglobin levels around 10 to 14 gdl, many patients may have no obvious symptoms. Sometimes they might experience palpitations or shortness of breath only with exertion, like climbing stairs. As the anemia worsens into the moderate range, with hemoglobin between 6 and 10 gdl, patients may notice fatigue, palpitations, or significant shortness of breath with activity. When hemoglobin falls below 6 GEDL, patients are considered to have severe anemia, and multiple body systems are affected. On the skin, you may see pallor, jaundice, and itching. In the eyes, jaundice may extend into the conjunctiva and sclera, and blurred vision may occur. The mouth can show glossitis, which is a smooth, inflamed tongue. The cardiovascular system is heavily stressed. Tachycardia, abnormal heart sounds, angina, or even heart failure can occur. In the lungs, patients may develop tachypnea, orthopnea, or shortness of breath at rest. Neurologically, they may complain of headache, dizziness, irritability, or impaired thought processes. The gastrointestinal system can also be affected, with loss of appetite, enlarged liver, or enlarged spleen. The musculoskeletal system may present with bone pain, especially in hemolytic anemias. Finally, general systemic symptoms of severe anemia include sensitivity to cold, weight loss, and extreme lethargy. As nurses, it's critical to monitor anemia symptoms closely because even a subtle change, like new onset fatigue or mild tachycardia, can be the first sign that a patient's anemia is worsening. Another visible sign of anemia, especially iron deficiency anemia, is spoon-shaped fingernails, also called koilonychia. With this condition, the nails become thin, brittle, and curve upward at the edges, resembling the shape of a spoon. This occurs because iron deficiency weakens the structure of the nail bed and interferes with normal keratin production. Patients may also report that their nails break easily or are slow to grow. It's important for us as nurses to notice physical signs like this because they can provide early clues about underlying nutritional deficiencies, especially in patients who may not yet have obvious systemic symptoms. If you see spoon-shaped nails during an assessment, it should prompt further questioning about fatigue, diet, and other anemia symptoms, as well as lab evaluation for hemoglobin and iron levels. Another important physical sign of anemia is glossitis, which means inflammation of the tongue. In this case, the tongue appears smooth, swollen, and beefy red. This sign is most commonly associated with vitamin B12 deficiency or folic acid deficiency, which cause macrocytic anemias. Pernicious anemia, in particular, often produces this symptom because the body cannot absorb vitamin B12 properly without intrinsic factor. Patients with glossitis may complain of soreness or burning of the tongue, difficulty eating spicy foods, or changes in taste. This is because the papillae, the small bumps on the tongue that contain taste buds, become atrophied. As nurses, recognizing this physical change is critical because it can point to a nutritional deficiency long before lab results are available. When we see a smooth, red tongue during assessment, it should prompt questions about the patient's diet, alcohol use, and absorption problems, as well as coordination for lab work and possible supplementation. Yet another physical sign of anemia is the presence of fissures at the corners of the mouth, also called angular cheilitis or angular stomatitis. These appear as painful cracks, redness, or sores at the mouth corners. This finding is most commonly associated with iron deficiency anemia and B vitamin deficiencies, including riboflavin B2, pyridoxine B6, and cobalamin B12. The lack of essential nutrients weakens the skin and mucous membranes, making them more prone to breaking and infection. Patients may complain of burning, soreness, or difficulty opening their mouths wide. In some cases, secondary infections with yeast or bacteria can worsen the condition. As nurses, when we see fissures at the mouth corners, we should think beyond a local skin issue and consider whether it could be an outward sign of nutritional anemia. This is why a thorough physical assessment is so important. It often gives us early warnings about what's happening inside the body. When diagnosing anemia, we rely on both lab tests and physical assessment findings. The most basic test is the complete blood count, or CBC, which gives us hemoglobin, hematocrit, and red blood cell indices such as mean corpuscular volume. These values help determine whether the anemia is microcytic, macrocytic, or normocytic. In more complex cases, a bone marrow biopsy may be ordered to evaluate how well the bone marrow is producing red blood cells. This is especially important in suspected aplastic anemia or cancers affecting the marrow. When pernicious anemia is suspected, blood tests can look for antibodies to intrinsic factor, since intrinsic factor is required for vitamin B12 absorption. Homocysteine levels may also be measured, as elevations can indicate folate or B12 deficiency. And in cases of blood loss anemia, identifying the source of bleeding, such as gastrointestinal bleeding from ulcers or colon cancer, is critical for treatment. Therapeutic measures always begin with addressing the underlying cause. For example, replacing iron in iron deficiency anemia, vitamin B12 injections in pernicious anemia, or treating chronic disease processes. Dietary supplements and nutritional changes may be recommended to correct deficiencies. For patients with chronic diarrhea, it is important to control the diarrhea because it prevents absorption of key nutrients like iron and vitamins. In severe anemia, when the patient is symptomatic or hemoglobin is dangerously low, a blood transfusion may be necessary to restore oxygen carrying capacity quickly. As LPNs, it is important to understand not only the lab values, but also the patient's clinical presentation and the nursing responsibilities related to these treatments. For example, monitoring transfusions for reactions, encouraging dietary intake of iron-rich foods, and teaching patients about adherence to supplements. When we apply the nursing process to a patient with anemia, we begin with data collection or assessment. This includes gathering subjective data, such as fatigue, weakness, or shortness of breath, and objective data like pallor, tachycardia, or abnormal lab values. We should also assess the patient's dietary habits, menstrual history, gastrointestinal symptoms, and family history of blood disorders. Next, we move to nursing diagnosis, planning, and implementation. Common nursing diagnoses for anemia include activity intolerance, fatigue, imbalanced nutrition, less than body requirements, or risk for injury related to dizziness or syncope. Planning involves setting measurable goals, such as maintaining hemoglobin within normal range, reducing fatigue, or improving nutritional intake. Implementation may include teaching about dietary iron sources, encouraging rest periods, monitoring oxygenation, and preparing the patient for blood transfusion or iron supplementation as ordered. Finally, while not listed on this slide, we always include evaluation, determining whether the interventions improved the patient's energy level, lab values, or overall quality of life. As LPNs, you play a key role in ongoing assessment, providing patient education, carrying out prescribed interventions, and reporting changes to the RN or healthcare provider. This slide presents a sample nursing care plan for a patient with anemia. The diagnosis is decreased activity tolerance related to tissue hypoxia and dyspnea. Remember, with anemia, the body has fewer red blood cells or less hemoglobin, which reduces oxygen delivery to tissues. This makes normal activities much more tiring for the patient. The expected outcome is that the patient will be able to complete daily activities with minimal assistance while showing an understanding of energy conservation. To achieve this, we begin by monitoring vital signs before and after activity. Patients with anemia may develop tachycardia or increased respiratory rate during exertion because their body is trying to compensate for low oxygen. A sudden drop in blood pressure when changing positions may also cause dizziness or fainting. If we notice that the pulse or respiratory rate rises more than 20% from baseline during activity, the activity should be reduced. This means the patient's body is under too much strain. We also teach the patient how to plan rest periods after activity. Alternating activity with rest helps conserve energy. If needed, we assist the patient with self-care activities such as bathing or dressing to reduce their exertion. Another key intervention is to limit unnecessary energy expenditure like long visits, frequent phone calls, or constant interruptions. Finally, if ordered, we administer oxygen therapy to relieve dyspnea because these patients don't have enough hemoglobin to carry oxygen to vital organs effectively. Overall, the nursing role is to balance activity and rest, conserve energy, and make sure patients stay safe while still maintaining independence. This nursing diagnosis addresses imbalanced nutrition, less than body requirements, which is common in anemia when patients either lack nutrients, have poor absorption, or don't understand proper diet choices. The expected outcome is that the patient will improve nutrition as shown by stable weight, hemoglobin, and hematocrit levels, and will also be able to identify and select foods that meet nutritional needs for anemia treatment. One intervention is to consult a dietitian, especially when the anemia is caused by dietary deficiencies. Dietitians provide individualized plans that balance iron, folic acid, and vitamin B12. For patients with folic acid deficiency, we teach them to include foods from all groups, especially leafy green vegetables, citrus fruits, and fortified cereals. For vitamin B12 deficiency, such as pernicious anemia, it's important to stress that oral B12 is not absorbed. These patients will require lifelong vitamin B12 injections. For iron deficiency anemia, education includes choosing high iron foods such as red meat, beans, spinach, and fortified cereals. Patients should also know how to properly take iron supplements. These should be paired with vitamin C-rich foods like citrus juice to enhance absorption, and patients should avoid taking iron with milk or antacids, which interfere with absorption. Overall, these interventions focus on correcting deficiencies, reinforcing education, and ensuring the patient can manage their nutrition independently after discharge. This nursing diagnosis is impaired oral mucous membrane integrity, which is common in patients with anemia, especially when caused by nutritional deficiencies. Patients may experience glossitis, a sore red tongue, or painful fissures in the mouth. These symptoms can interfere with eating and further worsen nutritional status. The expected outcome is that the patient will maintain intact oral mucous membranes. To achieve this, nurses should begin by monitoring the condition of the oral mucosa for redness, ulcers, or changes. We should also provide oral hygiene using gentle methods to keep the mouth clean and prevent infection. Encouraging patients to eat soft, bland foods reduces irritation and helps them maintain nutrition while healing occurs. A soft-bristled toothbrush is recommended to avoid trauma to the gums and oral tissues. For evaluation, we would expect the oral mucosa to be healed and intact, and that the patient can tolerate food without pain or irritation. The patient should also be able to verbalize the importance of diet, supplements, and oral care in preventing recurrence of these problems. Aplastic anemia, also called hypoplastic anemia, is a rare but serious disorder where the bone marrow fails to produce enough blood cells. Instead of active marrow, it becomes fatty and underactive. This condition can be fatal if left untreated. Let's look at the etiology or causes. Some cases are congenital, meaning patients are born with it. More often, it is acquired, resulting from exposure to toxins such as industrial chemicals, benzene, insecticides, or cancer treatments like chemotherapy and radiation. Certain infections, such as tuberculosis, hepatitis, or even autoimmune diseases, can also trigger marrow suppression. Now for the physiology or how it affects the body. In aplastic anemia, the marrow cannot produce enough blood cells. The cells that are made look normal in shape and size, but the quantity is severely reduced. This leads to a condition called pancytopenia, meaning a reduction in all three major cell lines: red blood cells, white blood cells, and platelets. Sometimes only one cell line is affected, but often all are reduced. The implications of pancytopenia are significant. With fewer red blood cells, patients experience severe anemia and fatigue. With low white blood cells, they are at high risk for infection. With low platelets, they are at risk for bleeding. This combination makes aplastic anemia a life-threatening condition requiring urgent diagnosis and management. Aplastic anemia, or hypoplastic anemia, causes pancytopenia, a reduction in red blood cells, white blood cells, and platelets. Because of this, the signs and symptoms reflect problems in all three blood cell lines. With low red blood cells, patients develop fatigue, pallor, and shortness of breath because their tissues are not receiving enough oxygen. As the anemia worsens, the heart compensates, leading to tachycardia and eventually heart failure if untreated. With low platelets, the patient is at high risk for bleeding. This shows up as ecchymoses, large bruises, and petechiae, small pinpoint hemorrhages. In severe cases, blood may ooze from mucous membranes, injection sites, or even vital organs, putting the patient at risk for internal bleeding. With low white blood cells, the immune system is severely weakened. This leaves the patient vulnerable to infections, which can progress quickly to sepsis. Ultimately, if aplastic anemia is untreated, the combination of infection and bleeding can lead to death. That is why this condition is considered a medical emergency, and treatment often involves transfusions, immunosuppressive therapy, or even bone marrow transplant. This slide shows a patient with ecchymosis, or large areas of bruising, which is a common finding in aplastic anemia. In aplastic anemia, the bone marrow is not producing enough blood cells. One of the most serious consequences is thrombocytopenia, or a decreased number of platelets. Since platelets are essential for clotting, patients with low platelet counts are prone to bleeding and bruising, even with very minor trauma, or sometimes without any injury at all. Ecchymoses are large, dark bruises caused by bleeding under the skin. In severe cases, bleeding may also occur as petechiae, tiny red or purple spots, or oozing from mucous membranes and injection sites. Internal bleeding, such as in vital organs, can also occur. For LPNs, it's critical to recognize these skin and mucosal changes as potential indicators of aplastic anemia or other bleeding disorders. Care priorities include protecting the patient from injury, avoiding unnecessary needle sticks, using soft toothbrushes and gentle hygiene measures, and reporting new bleeding signs promptly. This visual reminder helps us understand why patients with aplastic anemia must be monitored so closely for hemorrhage. This slide shows petechiae, which are tiny pinpoint hemorrhages in the skin. These spots do not blanch when pressed and are caused by bleeding under the skin due to a lack of platelets. In aplastic anemia, the bone marrow fails to produce enough blood cells, including platelets. Without platelets, the body cannot form clots effectively. This condition, called thrombocytopenia, leads to bleeding tendencies. Patients may develop petechiae on the legs, arms, or mucous membranes even without trauma. Petechiae are often an early sign of platelet deficiency. As thrombocytopenia worsens, patients may also develop ecchymoses, larger bruises, and bleeding from mucous membranes or injection sites. As nurses, it is critical to assess the skin carefully for petechiae, since they may be the first visible indicator of aplastic anemia or another bleeding disorder. Nursing care includes protecting the patient from injury, avoiding unnecessary needle sticks, and promptly reporting new bleeding to prevent life-threatening complications. To confirm a diagnosis of aplastic anemia, several important diagnostic tests are used. The first is a complete blood count, or CBC. Patients usually have very low counts across the board: red blood cells, white blood cells, and platelets. Interestingly, the red blood cell decline may lag slightly behind the drop in white cells and platelets, so pancytopenia may develop in stages. The most definitive test is a bone marrow biopsy. In a healthy patient, bone marrow should be red and active, filled with developing cells. In aplastic anemia, the biopsy may result in what's called a dry tap, meaning very little marrow is aspirated because it has been replaced with fatty or fibrotic tissue. On exam, the marrow often appears pale, yellow, and fatty instead of red and cellular. Additional lab tests include the total iron binding capacity, TIBC, and serum iron levels. These help differentiate aplastic anemia from iron deficiency anemia. In aplastic anemia, iron levels may be normal or even elevated because the problem isn't lack of iron. It's that the marrow cannot use it to make red blood cells. For LPNs, the key role is to understand what these diagnostic results mean, recognize the severity of pancytopenia, and support patients through the biopsy and frequent blood draws. In treating aplastic anemia, the goal is to restore or support the bone marrow's ability to make blood cells. The first step is early identification and correction of the underlying cause. If the anemia is due to a toxin or drug, removing that exposure can sometimes reverse the condition. Steroids and immunosuppressants are often used because aplastic anemia can be autoimmune in nature, with the body attacking its own bone marrow. Immunosuppressants such as antithymocyte globulin or cyclosporine can reduce immune destruction and allow the marrow to recover. Hormone therapy, particularly androgens like oxymethylone, may help stimulate red blood cell production, although this is not always effective. Colony-stimulating factors such as GCSF, granulocyte colony-stimulating factor, or erythropoietin may help the bone marrow make more white cells or red cells. These drugs are very expensive, and their use depends on the severity of the condition and available resources. Ultimately, for many patients with severe aplastic anemia, especially younger ones, a bone marrow or stem cell transplant is the only curative option. Supportive care, such as transfusions and infection prevention, is also critical in management. As nurses, managing a patient with aplastic anemia requires constant vigilance. These patients are at very high risk for bleeding and infection because of pancytopenia. The first priority is bleeding precautions. Because platelet counts are low, patients may bleed easily, even from minor injuries. We need to monitor CBC results closely and check the skin and mucous membranes for signs such as petechiae or ecchymoses. We must also avoid unnecessary needle sticks, use soft toothbrushes, and protect the patient from falls or trauma. The second priority is infection prevention. With very low white blood cells, even minor infections can become life-threatening. Standard infection control measures such as hand hygiene, limiting visitors, and monitoring for fever are critical. Patients may require protective isolation in severe cases. As LPNs, your role includes constant monitoring, reporting findings promptly, and educating patients and families about signs to watch for at home. The keywords here are: be safe, be vigilant, and act quickly if you see signs of bleeding or infection. Patients with aplastic anemia are at very high risk of bleeding due to low platelet counts. This slide outlines important interventions to prevent bleeding, and as nurses, these are essential for keeping our patients safe. First, we focus on reducing trauma. Patients should use an electric razor instead of a blade and a soft toothbrush or gauze instead of hard bristles or floss. We should avoid invasive procedures whenever possible, including enemas, suppositories, rectal temperatures, or intramuscular injections, since these can cause uncontrolled bleeding. Even common procedures must be modified. For example, when taking a blood pressure, the cuff should only be inflated until the pulse disappears to prevent bruising. Blood draws should be minimized by using existing access sites and grouping lab work together. If a draw or IV is done, firm pressure should be held for at least 5 minutes to prevent bleeding. Patients should wear shoes or slippers to prevent injury, and clutter should be cleared from their environment to avoid bumps and falls. We also avoid medications that interfere with platelets like aspirin or NSAIDs. Additional precautions include giving stool softeners to prevent straining, turning and moving patients gently, and even instructing them to blow their nose softly. Patients may also need to discuss the safety of sexual activity with their provider, as mucosal trauma could trigger bleeding. As nurses, the key is to remain vigilant, reinforce these safety measures, and educate patients and families on how critical bleeding prevention is in aplastic anemia. In aplastic anemia, the patient has very low white blood cells, making them extremely vulnerable to infection. Infection prevention is therefore one of the most important aspects of nursing care. First, we should place the patient in a private room to minimize exposure. All staff and visitors must wash their hands before entering, and we need to teach the patient and family to do the same before meals, after toileting, and after any contact. We must also limit exposure to infection sources. Visitors with known infections should not enter the room. The patient should avoid flowers, plants, or unwashed fruits and vegetables since these can carry bacteria or fungi. We should minimize the use of invasive devices like indwelling catheters because they provide a direct route for infection. If an invasive procedure is necessary, we must use strict aseptic technique. If the patient develops a fever, this must be treated as an emergency. Even a small rise in temperature may indicate infection and should be reported immediately. For fever, acetaminophen can be used, but aspirin should be avoided because it increases the risk of bleeding. As LPNs, your role is to practice and reinforce infection prevention measures, educate the patient and family, and report any early signs of infection promptly. These interventions can save lives. Sickle cell anemia is an inherited blood disorder where normal round red blood cells mutate into a crescent or sickle shape. This change occurs because of an abnormal type of hemoglobin called hemoglobin S, HbS. It is an autosomal recessive disorder, meaning that a child must inherit 2 abnormal genes, one from each parent, to have the disease. If they inherit only one gene, they will carry the trait but usually not show severe symptoms. Interestingly, signs and symptoms don't appear until after 4 to 5 months of age. This is because infants are protected by fetal hemoglobin, HbF, which prevents red cells from sickling. Once HbF declines and is replaced by HbS, symptoms begin to develop. From a physiology perspective, sickle cells are different in 3 key ways. They are rigid and sticky, so they clump together and block blood flow. They don't last as long, only about 10 to 20 days compared to normal RBCs that live 120 days. This leads to chronic anemia. They cause vaso-occlusion, meaning they block small blood vessels, leading to tissue hypoxia, pain crises, and potential organ damage. The diagram here shows the difference between normal RBCs, which move smoothly through vessels, and sickle cells, which clump together and obstruct blood flow. This blockage is what causes most of the complications of the disease, including severe pain, organ ischemia, and risk of stroke. When we discuss sickle cell anemia, it is important to understand its cultural and global context. In the United States, sickle cell anemia is the most common inherited blood disorder among African Americans. About 1 in 365 African American children are born with the disease, and about 1 in 13 carry the trait. Globally, sickle cell is found in areas where malaria is or was historically common, including Africa, the Middle East, parts of India and Asia, the Mediterranean region, and the Caribbean. The reason is evolutionary. Individuals with sickle cell trait, meaning they carry one abnormal gene but not the full disease, have a survival advantage against malaria. Their red blood cells are less hospitable to the malaria parasite, which lowers the risk of severe or fatal infection. This survival advantage explains why sickle cell disease continues to be more common in these populations. However, for individuals with 2 copies of the abnormal gene, the protective effect turns into a serious lifelong illness. As nurses, it's essential to keep this cultural context in mind when assessing patient risk, providing genetic counseling, and offering education about carrier screening in communities where sickle cell is more prevalent. This image shows the difference between normal red blood cells and the abnormal sickled cells seen in sickle cell anemia. Normal RBCs are round, flexible, and smooth, which allows them to travel easily through blood vessels and deliver oxygen efficiently. They live for about 120 days in circulation. In sickle cell anemia, the abnormal hemoglobin S causes cells to become crescent-shaped, rigid, and sticky. These cells clump together, block small blood vessels, and restrict blood flow. Instead of lasting 120 days, sickled cells are fragile and survive only 10 to 20 days, leading to chronic anemia. This sickling process is not constant. It often occurs during times of low oxygen, dehydration, infection, or stress, which can trigger a sickle cell crisis. During a crisis, patients may experience severe pain, tissue hypoxia, and potential organ damage. The important takeaway from this image is that sickle cells are not only misshapen but also dysfunctional. They both shorten RBC lifespan and cause blockages, which explains why patients suffer from both anemia and vaso, occlusive complications. When we diagnose sickle cell anemia, several key tests are used. The SickleDex test can be performed as an initial screen. It identifies the presence of hemoglobin S, but does not distinguish between sickle cell disease and trait. For confirmation, we use hemoglobin electrophoresis, which separates different types of hemoglobin and definitively identifies HbS. Routine labs often show low hemoglobin and red blood cell counts due to chronic anemia. Patients may also have an elevated white blood cell count during crises or infection. Another important finding is an increased reticulocyte count, reflecting the bone marrow's attempt to compensate for rapid red cell destruction. Now let's review therapeutic measures. The main focus of nursing care is crisis prevention and management. Education is essential. Patients must avoid triggers like dehydration, extreme temperatures, stress, and infections. Antibiotics may be used prophylactically in children and for treatment during infection. For severe pain, strong analgesics are necessary, often opioids during crisis. Blood transfusions may be given to improve oxygen carrying capacity and reduce sickling. Oxygen therapy is used to reduce hypoxia, though it does not reverse sickling once it has occurred. Adequate hydration, both oral and intravenous, helps reduce blood viscosity and flush sickled cells through the kidneys. In some cases, bone marrow or stem cell transplantation offers the only potential cure, though it is not an option for all patients due to donor and risk limitations. As LPNs, your role is to provide supportive care, reinforce education about prevention, and monitor for complications such as infection, pain, and signs of organ damage. This slide highlights the signs and symptoms of sickle cell anemia, which are caused by two main problems: chronic anemia and blocked blood flow from sickled cells. Let's go through each body system. Brain. Patients are at risk for strokes, thrombosis, and hemorrhage because sickled cells can block cerebral blood vessels. Strokes are one of the most serious complications in children. Eyes. Poor circulation may cause retinal or conjunctival hemorrhage, leading to vision problems or even blindness. Heart. Chronic anemia and constant strain on the heart can result in heart failure. Lungs. Patients may develop atelectasis, infarctions, and pneumonia. Acute chest syndrome, a life-threatening complication, can mimic pneumonia and requires urgent care. Kidneys. Damage to kidney vessels may cause dilute urine, diuresis, or hematuria, and over time can lead to chronic kidney disease. Abdominal organs. The spleen is often affected, leading to splenic enlargement, infarction, and eventual loss of spleen function, autosplenectomy. This greatly increases infection risk. Patients may also have gallstones from excess bilirubin due to RBC breakdown and hepatomegaly. Bones and joints. Painful episodes are common, especially in the hands and feet, hand-foot syndrome in children. Penis. Males may experience priapism, a prolonged and painful erection caused by trapped sickled cells. Skin. Poor circulation leads to stasis ulcers, particularly around the lower legs and ankles. As LPNs, it is critical to recognize these symptoms early, provide supportive care during crises, and teach patients how to prevent triggers such as dehydration, infection, and extreme temperature exposure. When caring for a patient with sickle cell anemia, nursing interventions are aimed at managing pain, preventing complications, and monitoring for signs of crisis. We start with data collection or assessment. A key area to monitor is the neurological status, since patients are at high risk for stroke. We assess level of consciousness, orientation, muscle strength on both sides, pupil size, and speech patterns. Any changes may indicate a neurologic emergency. For pain management, we use warm compresses, warm blankets, and ensure the room temperature is above 72 degrees Fahrenheit to prevent vasoconstriction. Cold compresses should be avoided, as cold can trigger sickling by reducing blood flow. We also teach patients to avoid restrictive clothing or raising the knees in bed, since both can impair circulation. Pain relief is essential. These patients often require opioid analgesics or acetaminophen. Aspirin should be avoided because of its effects on platelets and risk of bleeding. During the acute phase of a crisis, we encourage bed rest to reduce oxygen demand and prevent further complications. Once stable, gradual mobility can be encouraged. As nurses, our role is to combine careful assessment, comfort measures, and safe medication use to help patients manage sickle cell crises and prevent long-term damage. Patient education is one of the most important aspects of managing sickle cell anemia. Nurses play a key role in teaching patients how to prevent crises and manage complications. Crisis prevention centers around avoiding factors that lower oxygen in the blood. Patients should avoid exposure to cold, since cold temperatures cause vasoconstriction and sickling. They should also avoid infections. Good hand hygiene, vaccinations, and early treatment of illness are crucial. Finally, they should avoid strenuous exercise, which increases oxygen demand and can trigger a crisis. Education is especially important during periods of remission, when the patient is stable and able to focus on learning preventive strategies. Education focuses heavily on crisis prevention. Patients must understand what to avoid, since many environmental and lifestyle factors can trigger sickling. First, they should avoid tight clothing, which restricts circulation. They should avoid strenuous exercise because increased oxygen demand can lead to hypoxia and trigger a crisis. Alcohol should be avoided as it can cause dehydration and impair red blood cell function. Cold temperatures should be avoided since cold leads to vasoconstriction and impaired blood flow. Patients should not smoke because smoking decreases oxygen delivery and increases the risk of lung complications. They should avoid traveling in unpressurized aircraft where low oxygen levels can trigger sickling. Finally, they must limit exposure to infections by practicing good hygiene, staying up to date with vaccinations, and seeking care promptly if illness develops. As nurses, we should stress that these precautions are not just recommendations. They are life-saving measures that reduce the risk of painful crises and long-term organ damage. For infection prevention, children with sickle cell anemia are often prescribed low-dose penicillin, starting in infancy and continuing through early childhood. This greatly reduces the risk of life-threatening infections like pneumonia and sepsis. Some patients require frequent blood transfusions to maintain healthy levels of red blood cells and oxygen. However, repeated transfusions can lead to iron overload, which damages organs. To prevent this, medications such as deferocerox, Jadanu, are given to bind excess iron and remove it from the body. Another important therapy is hydroxyurea. This medication increases the amount of fetal hemoglobin, HbF, which prevents red cells from sickling. Hydroxyurea has been shown to reduce the frequency of painful crises, hospitalizations, and the need for transfusions. As LPNs, your role is to reinforce education, encourage medication adherence, and help patients understand how daily lifestyle choices affect their long-term health. Polycythemia is a disorder in which the body produces too many red blood cells, making the blood thick and sluggish, almost like sludge. This increased viscosity makes it harder for blood to circulate and increases the risk for blood clots, strokes, and heart attacks. There are two types of polycythemia: polycythemia vera, PV. This is a rare type of blood cancer caused by a genetic mutation, most often the JAK2 mutation. In PV, the bone marrow produces too many cells, not just red blood cells, but also white blood cells and platelets. As a result, the bone marrow becomes packed with cells, and organs like the spleen and liver can become congested with blood. PV is chronic and progressive if untreated. Secondary polycythemia. This is not cancer, but rather a compensatory mechanism the body uses in response to chronic low oxygen, hypoxia. Causes include COPD, heart failure, living at high altitudes, and smoking. The body increases red blood cell production to try to carry more oxygen, but this also thickens the blood. For nurses, it's important to understand the difference. PV is due to an intrinsic bone marrow problem, while secondary polycythemia results from an external trigger like hypoxia. Both conditions place the patient at risk for clotting complications and need ongoing management. When assessing a patient with polycythemia, it's important to recognize the wide range of signs and symptoms, which occur because the blood becomes too thick and circulation is impaired. Circulatory symptoms often include hypertension, dark flushed skin, and itching, particularly after a warm bath or shower. This itching is caused by increased histamine release from overactive blood cells. Patients may also experience abdominal fullness and pain due to splenomegaly, as the spleen becomes congested with excess blood cells. Symptoms are common and include headache, dizziness, vertigo, visual disturbances, and tinnitus. These result from sluggish blood flow and reduced oxygen delivery to the brain and sensory organs. Bleeding and clotting risks occur simultaneously. Although blood is thick and prone to clotting, patients can also develop acquired von Willebrand disease, a bleeding disorder that leads to nosebleeds, easy bruising, or prolonged bleeding. They are also at risk for chest pain and dyspnea due to decreased oxygenation and possible blood clots in the lungs or coronary arteries. Finally, panmyelosis, the overproduction of all bone marrow components, including red blood cells, white blood cells, and platelets, is the underlying problem in polycythemia vera, and it contributes to all these symptoms. As nurses, our role is to monitor for these clinical manifestations and report them promptly. Recognizing these early signs can help prevent life-threatening complications such as stroke, myocardial infarction, or pulmonary embolism. When we talk about diagnosing polycythemia, the most important tests look at the number and concentration of blood cells. A CBC will show an elevated red blood cell count, often greater than 6 million per microliter. Hemoglobin levels are typically greater than 18 grams per deciliter, and hematocrit levels often rise above 55%. To confirm the type of polycythemia, we also look at erythropoietin levels. In polycythemia vera, these levels are low because the bone marrow is producing red cells without being stimulated. Genetic testing for JAK2 or TET2 mutations can confirm PV, since these mutations drive uncontrolled cell growth. Finally, a bone marrow aspiration can reveal overcrowded marrow filled with red cells, white cells, and platelets. Now let's talk about treatment. There is no cure for polycythemia vera, so the goal is to control symptoms, reduce blood viscosity, and prevent complications. The first-line treatment is therapeutic phlebotomy. This is like a controlled blood donation, where blood is removed 1 to 2 times per week until levels stabilize, and then repeated every 2 to 3 months as maintenance. Other therapies include antihistamines for itching and low-dose aspirin to reduce the risk of clot formation. In some cases, chemotherapy agents or radiation therapy are used to suppress bone marrow activity when phlebotomy isn't enough. Antidepressants may also be prescribed to help with the mental health burden of a chronic disease. The key nursing takeaway is that polycythemia management focuses on keeping the blood thin enough to circulate well and preventing life-threatening complications such as strokes, heart attacks, and blood clots. When educating patients with polycythemia, our primary goal is to reduce complications from thickened blood and support safe self-care. First, we encourage patients to stay well hydrated. Drinking about 3 liters of fluid daily helps keep the blood less viscous, making circulation easier. Of course, this recommendation must be adjusted for patients with heart failure or kidney disease, so we always check for contraindications. We also teach patients to avoid restrictive clothing. Tight garments can slow circulation in the arms or legs, which increases the risk of blood clots. Instead, patients should wear loose, comfortable clothing to keep blood flowing freely. Elevating the feet when sitting can help improve venous return and decrease pooling of blood in the lower extremities. This is a simple but effective lifestyle modification. Because repeated phlebotomy can eventually cause iron deficiency, we teach patients to watch for symptoms like unusual fatigue, brittle nails, or pallor. Lastly, we emphasize the importance of monitoring for bleeding complications, since polycythemia patients may also have abnormal platelet function. They should report nosebleeds, gum bleeding, blood in stool or urine, or easy bruising immediately. As nurses, we must reinforce these teaching points regularly because proper self-care plays a major role in preventing serious complications such as stroke, heart attack, or hemorrhage in polycythemia patients. This slide introduces disseminated intravascular coagulation, or DIC, which is a very serious hemorrhagic disorder. Let's start with the pathophysiology. In DIC, the body begins to form excessive clots throughout the small blood vessels. This process consumes all of the clotting factors and platelets. At first, the patient may have tiny clots forming everywhere, which can block circulation to vital organs. But because the clotting factors are being used up, the patient then begins to experience uncontrolled bleeding from multiple sites, such as IV lines, mucous membranes, and internal organs. So, DISC is sometimes called a clotting and bleeding disorder happening at the same time. In terms of etiology, this slide lists major trauma, which is correct. Trauma can release large amounts of tissue factor into the bloodstream, which triggers abnormal clotting. But DIC is also seen with sepsis, obstetric complications like amniotic fluid embolism or placental abruption, malignancies such as leukemia, transfusion reactions, and shock. For nurses, it's important to remember that DIC is always a secondary condition. It develops because of another underlying disease or injury. That's why treatment must focus on both controlling the bleeding and treating the underlying cause. Now let's look at the signs and symptoms of DIC. The first thing to remember is that DIC has a dual presentation, clotting and bleeding at the same time. Patients often present with abnormal bleeding that may appear as bruises, petechiae, bleeding from IV sites, gums, or even spontaneous bleeding from internal organs. Patients may also report joint pain or muscle pain, which happens because of tiny blood clots forming inside small vessels that block blood flow. Nausea and vomiting can also occur, sometimes due to organ ischemia or bleeding in the GI tract. As the condition progresses, patients may go into organ system failure because the small blood clots cut off oxygen and nutrients to vital organs like the kidneys, lungs, or liver. In severe cases, patients may develop seizures from lack of oxygen to the brain, and if not treated quickly, they may progress to shock and coma. Unfortunately, if DIC cannot be controlled, it can lead to death. As nurses, it is critical to recognize early bleeding and clotting signs so the healthcare team can intervene promptly. DIC is a medical emergency and outcomes depend heavily on fast recognition and treatment. Let's focus now on the bleeding signs and symptoms of DIC. Because clotting factors are being used up, patients will often bleed in multiple places. One of the earliest signs is easy bruising even without trauma. You may also see petechiae, which are tiny pinpoint red or purple spots caused by bleeding under the skin, and ecchymosis, which are larger bruises. Bleeding can also occur internally. Blood in the urine may indicate bleeding in the urinary tract, while black, tarry stools point to gastrointestinal bleeding. Patients may have nosebleeds or bleeding gums even without obvious cause. Another important sign is the new onset of painful joints, which may occur because small blood clots and bleeding collect inside the joint spaces. Remember, in DIC, the patient is at risk of both clotting and bleeding at the same time, so careful monitoring is critical. Now let's look at the diagnostic test for disseminated intravascular coagulation, or DS. DIC is diagnosed through a combination of lab findings rather than a single test. First, prothrombin time, or PT, is prolonged, which means blood is taking longer to clot. Similarly, the activated partial thromboplastin time, or APTT, is also prolonged, showing that both intrinsic and extrinsic clotting pathways are affected. The platelet count is typically low because platelets are being used up in widespread clotting. Hemoglobin levels may drop due to ongoing bleeding. One key marker we look for is the D-dimer, which is elevated. This indicates increased fibrin breakdown, showing that clots are forming and being destroyed at the same time. Fibrinogen levels are usually reduced because the body is consuming clotting factors faster than it can produce them. Finally, BUN may be elevated if bleeding occurs in the digestive tract because the body absorbs digested blood proteins as urea. As LPNs, it's important to know these labs and understand that changes in clotting studies often point to DIC early on, even before symptoms become obvious. Now let's review the therapeutic interventions for disseminated intravascular coagulation, or DICE. The number one priority is always to treat the underlying cause. DIC is not a disease itself, it's a complication of something else, such as trauma, infection, or cancer. If the root problem is not corrected, the clotting and bleeding cycle will continue. For immediate management, you should expect provider orders for blood product replacement. Packed red blood cells may be given to restore oxygen carrying capacity if anemia is severe. Fresh frozen plasma, or FFP, contains clotting factors and helps replace what the body has depleted. Platelets are often transfused because they are used up quickly in the clotting process. Cryoprecipitate is rich in fibrinogen, von Willebrand factor, and other clotting proteins. This is especially helpful when fibrinogen levels are very low. As LPNs, you will not independently initiate these transfusions, but you will play a vital role in monitoring patients closely during transfusions, watching for transfusion reactions, checking vital signs, and reporting changes immediately. It's important to remember that treatment for DIC is supportive and aimed at stopping the cycle of clotting and bleeding while correcting the underlying condition. Now let's talk about the nursing care for patients with DIC, or disseminated intravascular coagulation. Your main role as an LPN is to monitor, protect, and support the patient. First, you must recognize and report bleeding early. This includes checking for bruising, petechiae, bleeding gums, hematuria, or black tarry stools. Even subtle changes can indicate worsening DIC and must be reported immediately to the RN or provider. Second, we must focus on preventing trauma and further bleeding. Use gentle handling during care, avoid unnecessary needle sticks, and use the smallest gauge needle possible if IV access is needed. Encourage the use of soft toothbrushes or mouth swabs, and avoid procedures that could increase bleeding risk. Finally, patient and family teaching is critical. Families need to understand why the patient is at risk for both bleeding and clotting. Reinforce safety measures, explain why visitors may need to be limited, and provide emotional support as this condition is often frightening and life-threatening. Remember, the nurse's role in DIC is not to cure the disorder, but to provide close monitoring, immediate reporting, and supportive care to prevent complications. Now we're moving on to immune thrombocytopenic purpura, or ITP. In this disorder, the immune system destroys platelets, which are critical for blood clotting. Without enough platelets, patients are at high risk for bleeding. This condition may be acute, often seen in children after a viral illness, or it may be chronic, more common in adults, especially women under 40. The etiology can include an acute viral illness where the immune system mistakenly attacks platelets after fighting infection. Certain drug reactions like from sulfa antibiotics or heparin can also trigger it. And finally, immune system dysfunction such as autoimmune diseases like lupus can be a cause. As LPNs, it's important to remember that the hallmark of ITP is low platelets with increased bleeding risk, but the rest of the blood counts like red and white cells are usually normal. Patients may look well otherwise, but even small injuries can be dangerous. Think about patient teaching, avoid trauma, avoid aspirin and NSAIDs, and report any unusual bruising or bleeding right away. On this slide, we are looking at the signs and symptoms of immune thrombocytopenic purpura. The biggest concern is bleeding. Because platelets are destroyed, the patient cannot clot effectively. One of the earliest signs is petechiae, those tiny pinpoint red or purple spots you see on the photo here. They are caused by small hemorrhages under the skin. We can also see ecchymosis, which are larger bruises. These bruises may appear after very minor trauma or sometimes even spontaneously. Other bleeding manifestations may include nosebleeds, bleeding gums, or prolonged bleeding after injury. As LPNs, you must be alert for these signs and report them promptly, since bleeding can progress quickly and even become life-threatening. Remember, in ITP, the rest of the blood counts are usually normal. The problem is specifically low platelets. Now let's review the diagnostic tests for ITP. The hallmark finding is a low platelet count. Normal platelet counts range from 150,000 to 450,000 per microliter of blood. In ITP, platelet counts can fall dangerously low, and if they drop below 20,000, the patient is at high risk for spontaneous bleeding, even without trauma. Another test you may see is a bleeding time test, which reflects how long it takes for a small cut to stop bleeding. In ITP, because there are so few platelets, the bleeding time is prolonged. Finally, a bone marrow aspiration may be performed. This test helps rule out other bone marrow disorders like leukemia or aplastic anemia. In ITP, the bone marrow usually shows normal or even increased numbers of megakaryocytes, which are the cells that produce platelets. This finding confirms that the problem is platelet destruction by the immune system, not decreased production. As LPNs, remember that your role is not to diagnose, but to recognize abnormal platelet levels and understand their significance in patient safety. Now let's focus on the therapeutic interventions for immune or idiopathic thrombocytopenia purpura, also known as ITP. In some mild cases, especially in children, ITP may resolve on its own without treatment. However, if the platelet count is very low or if bleeding is present, interventions are necessary. Steroids such as prednisone are often the first line of therapy. They help suppress the immune system so it stops. If steroids are not effective, other immunosuppressive drugs, sometimes referred to as chemotherapy agents like rituximab, may be used. Transfusions of platelets may be given in cases of severe bleeding, but this is usually temporary since the immune system can still attack the transfused platelets. Another option is intravenous immunoglobulin, or IVIG, which can quickly raise platelet counts by blocking the immune destruction process. Vitamin K is sometimes given to support clotting, but it is not the main treatment since the problem is platelet destruction, not vitamin K deficiency. In severe or chronic cases, a splenectomy, which is the surgical removal of the spleen, may be considered. The spleen is the site where platelets are often destroyed, so removing it can improve platelet survival. As nurses, it's important to educate patients and families about treatment options, side effects of steroids and immunosuppressants, and the importance of monitoring for bleeding. This condition requires careful follow-up and sometimes long-term therapy. Now let's talk about nursing care and patient education for immune or idiopathic thrombocytopenia purpura, or ITP. As LPNs, your role will focus heavily on patient safety, especially related to bleeding precautions. Patients with ITP are at risk for serious bleeding even from minor trauma, so teaching them how to protect themselves is critical. You should remind patients to avoid activities that can cause injury, such as contact sports, and encourage them to use soft toothbrushes and electric razors. Even small cuts or bruises can become dangerous. Education also includes teaching patients to recognize the early warning signs of bleeding. These include easy bruising of the skin, tiny pinpoint red spots called petechiae, and larger dark purple areas called ecchymosis. Patients must also watch for more serious symptoms like blood in the urine, black tarry stools, nosebleeds, bleeding gums, heavier vaginal bleeding, and new painful joints. If any of these occur, patients must notify their healthcare provider immediately. Quick reporting allows for prompt intervention to prevent life-threatening complications. Finally, remember that patient and family education is ongoing. Many patients will need repeated reminders and support to follow safety measures and to recognize when urgent care is needed. Now let's review bleeding precautions, which are vital for patients with bleeding disorders like ITP, aplastic anemia, or DIC. First, we encourage patients to use an electric razor instead of a blade razor. This helps reduce the chance of cuts and uncontrolled bleeding. Along the same lines, a soft toothbrush should be used instead of a hard one to avoid trauma to the gums. We also avoid invasive procedures and injections whenever possible because punctures create bleeding risks that may not stop easily. If a blood draw is absolutely necessary, we must apply firm pressure to the site for at least 5 minutes. When checking blood pressure, avoid prolonged inflation or high cuff pressures that could cause bruising. Patients should wear shoes or slippers to prevent foot injuries and avoid bumping into furniture or falling. Even minor bumps can cause internal bleeding or large bruises. Medications matter too. NSAIDs like aspirin, ibuprofen, or naproxen should be avoided because they interfere with platelet function. Instead, stool softeners should be given as prescribed to prevent straining during bowel movements, which could cause rectal bleeding or hemorrhoids. Nurses should also handle patients gently, avoiding rough movements or friction from bedding. Even sneezing or nose blowing should be done gently, since vigorous force can cause nosebleeds. The key here is safety. Everything we do should minimize the risk of trauma and bleeding for these patients. Now let's move into hemophilia, a well-known inherited bleeding disorder. Pathophysiology first. Hemophilia occurs because the body is missing specific clotting factors needed to form a stable clot. The two main types are hemophilia A, which results from a deficiency in factor 8, and hemophilia B, which is caused by a deficiency in factor 9. Both lead to an inability to properly form clots, which increases the risk of prolonged bleeding, even from small injuries. Etiology. Hemophilia is an inherited disorder passed through an X-linked recessive pattern. This means the gene responsible is carried on the X chromosome. Since males only have one X chromosome, they are much more likely to be affected. Females can be carriers and sometimes have mild symptoms, but are usually not severely affected. It's important for nurses to recognize that these patients are at risk not only for external bleeding, but also for dangerous internal bleeding into joints, muscles, or organs, which can be life-threatening. For LPNs, knowing the type of hemophilia, family history, and genetic background helps us understand the severity and tailor patient teaching. Now let's go over the signs and symptoms of hemophilia. The biggest issue is uncontrolled bleeding, which can occur either after an injury or sometimes spontaneously. Bleeding into the joints, called hemarthrosis, is a hallmark sign. It causes pain, swelling, warmth, and decreased movement of the joint. Repeated joint bleeds can lead to permanent joint damage and arthritis. Bleeding into the muscles can cause swelling, pain, and sometimes nerve compression. For example, if blood pools in a large muscle group like the thigh, it can press on nerves and blood vessels, leading to numbness, tingling, or impaired circulation. In the subcutaneous tissue, patients may develop large bruises or hematomas even from minor bumps. This is a visible warning sign that clotting is impaired. The most dangerous complication is bleeding into the brain. This can occur after even minor head trauma or sometimes spontaneously. Symptoms may include headache, vomiting, confusion, seizures, or coma. This is a life-threatening emergency and must be recognized quickly. As LPNs, it is vital to know where bleeding occurs and how it presents, because early recognition and reporting can save lives. Now let's talk about diagnostic tests for hemophilia. The first important test is the partial thromboplastin time, or PTT. This test looks at how long it takes for blood to clot through the intrinsic pathway of the coagulation cascade. In hemophilia, the PTT is usually prolonged, meaning it takes much longer for the blood to clot. Next, we look at clotting factor levels. This is the most specific test because it measures the actual amount of clotting factors in the blood. In hemophilia A, patients will have low or absent factors E8, and in hemophilia B, they will have low or absent factor 9. It's important to note that platelet counts and PT, prothrombin time, are usually normal in hemophilia, which helps distinguish it from other bleeding disorders. For nurses, understanding these tests helps explain why a patient with hemophilia may bruise and bleed so easily, even though their platelet count looks normal. Now let's look at treatment for hemophilia. First, it's important to remember there is no cure for hemophilia. It is a lifelong genetic disorder, so the focus of care is management and prevention of bleeding. One medication used is desmopressin, also called DDAVP. This drug can help the body release more factor C8 from storage sites in blood vessel walls. It is given either as an injection or as a nasal spray, and it is especially useful for people with hemophilia A who have mild to moderate disease. The mainstay of treatment is clotting factor replacement. Patients with hemophilia A receive factor 8, while patients with hemophilia B receive factor 9. These clotting factors can be given regularly to prevent bleeding episodes or as needed when bleeding occurs. In emergencies or when factor products are not available, patients may receive plasma products, but routine whole blood transfusions are not the standard of care today. As nurses, it's critical to remember that these patients are at risk for life-threatening bleeding, even from minor injuries. Our role includes monitoring for bleeding, ensuring prompt administration of prescribed factor replacement, and teaching patients how to prevent injury. Leukemia is a type of blood cancer that starts in the bone marrow, where blood cells are made. In leukemia, the bone marrow produces large numbers of abnormal, immature white blood cells called blasts. These cells take up space in the bone marrow but do not function normally. Because of this, the body cannot fight infections effectively. Although the exact cause of leukemia is not known, we do recognize several risk factors. These include exposure to certain viruses, genetic factors such as Down syndrome, and exposure to radiation or chemotherapy in the past. Environmental exposures like certain chemicals such as benzene and lifestyle factors such as smoking may also increase the risk. As nurses, it is important to remember that patients with leukemia are highly susceptible to infections due to their dysfunctional white blood cells, and they may also develop anemia and bleeding problems because abnormal cells crowd out normal red blood cells and platelets. Our role is to recognize these complications early and provide supportive care while treatment is ongoing. Leukemia is divided into 4 major types based on whether it is acute or chronic, and whether it involves lymphocyte or myeloid cells. Acute lymphocytic leukemia, or AL, is the most common type of leukemia in children. It has a rapid onset and progression but responds well to treatment, especially in young patients. Acute myelogenous leukemia, or AML, usually occurs in adults and progresses quickly. It develops from the myeloid stem cells and requires immediate treatment, often with chemotherapy and sometimes stem cell transplant. Chronic lymphocytic leukemia, or CLL, is the most common leukemia in older adults, especially those over age 55. It progresses slowly and may be monitored for some time before treatment is necessary. Chronic myelogenous leukemia, or CML, is associated with a specific genetic abnormality called the Philadelphia chromosome. It often progresses slowly at first, but can enter a more aggressive acute phase. As nurses, it's important to know these types because the age of the patient, the speed of progression, and the treatment plan vary depending on the type of leukemia.
When assessing patients with leukemia, it's important to recognize that signs and symptoms result from three main problems: the overproduction of immature white blood cells, the suppression of normal red blood cells and platelets, and bone marrow infiltration. Patients often present with fever, frequent infections, and malaise because their abnormal WBCs cannot fight pathogens effectively. You may also notice pallor, weakness, tachycardia, and palpitations, all of which are related to anemia. Bleeding problems are common due to reduced platelet counts. Watch for bruising, nosebleeds, and prolonged bleeding. Leukemic cells also invade the bone marrow and bone, causing sternal or rib pain and sometimes abdominal pain if organs like the liver or spleen enlarge. Finally, the central nervous system can be affected, leading to headaches, confusion, or even seizures. As LPNs, remember, many of these signs may appear subtle at first. Your role is to observe, document, and promptly report them to the healthcare team. When diagnosing leukemia, the first step is usually a complete blood count, or CBC. This test will often show low platelets, low red blood cells, and low mature white blood cells because the bone marrow is overproducing immature cells. The bone marrow aspiration is the most important confirmatory test. A sample of bone marrow is examined under the microscope to look for blast cells, or immature leukemic cells, and to measure the extent of abnormal growth. This confirms the diagnosis. A lumbar puncture may also be ordered, especially in acute leukemias, to determine if the cancer has spread to the central nervous system, which can change treatment plans. Lastly, genetic analysis is important. For example, the presence of the Philadelphia chromosome is a strong marker of chronic myelogenous leukemia and guides targeted treatment with drugs like imatinib. As LPNs, you won't interpret these tests, but you will be responsible for preparing patients, explaining procedures, and supporting them through what can be an overwhelming diagnostic process. Let's go over how leukemia is treated. The first line of treatment is chemotherapy. These are powerful drugs designed to kill rapidly dividing cancer cells. They are usually given in cycles because while they kill leukemic cells, they also damage healthy cells, especially hair, skin, and the lining of the GI tract. Radiation therapy is sometimes used, though not as commonly as chemotherapy. It may be used when leukemia cells collect in a specific location, like the brain, or to prepare a patient for a bone marrow or stem cell transplant. Stem cell transplant, also known as bone marrow transplant, is one of the most aggressive treatments, but can offer the chance of a cure. The patient's diseased marrow is destroyed with high-dose chemotherapy or radiation, and then healthy stem cells are infused to rebuild the blood-forming system. Finally, we have biological therapies. These include newer targeted treatments like monoclonal antibodies or drugs that specifically attack abnormal proteins. For example, patients with chronic myelogenous leukemia often benefit from imatinib Gleevec, which blocks the Philadelphia chromosome's abnormal activity. As LPNs, you will not administer chemotherapy or transplants, but you will play an essential role in monitoring patients, preventing infection, providing comfort, and supporting them through difficult side effects. When caring for a patient with leukemia, our number one priority is infection and bleeding prevention. Because chemotherapy and the disease itself lower white blood cells, patients are at extreme risk for infection. That's why we monitor vital signs and temperature every 4 hours, since even a low-grade fever could mean sepsis. We must carefully watch for signs and symptoms of infection and bleeding, things like bruising, petechiae, nosebleeds, coughing up blood, or unusual fatigue. Protection includes using neutropenic precautions, good hand hygiene, no fresh flowers or raw fruits and vegetables, and wearing a mask when appropriate. Because patients are often weak and tired, we support them with ADLs, energy conservation, rest, and good nutrition. We should also assess for pancytopenia, a condition where all blood cell lines, RBCs, WBCs, and platelets are decreased. This puts the patient at risk for infection, anemia, and bleeding all at once. Oral care is especially important. Chemotherapy damages the mucous membranes, so we assess the mouth for redness, swelling, or sores. Use a soft bristle toothbrush and avoid irritating agents like lemon glycerin swabs, smoking, alcohol, acidic foods, or very hot or cold foods. Commercial mouthwashes are too harsh. Dentures should be removed at night to prevent irritation. As LPNs, your role is to monitor closely, encourage safe practices, and report changes immediately. Even small issues like a new bruise or mouth sore can become dangerous quickly in these patients. Multiple myeloma is a cancer of the plasma cells, which are a type of white blood cell found in the bone marrow. In this condition, plasma cells grow out of control and crowd out normal bone marrow. These malignant cells form tumors that destroy bone tissue, causing painful lesions, bone thinning, and fractures. As the cancer progresses, the abnormal plasma cells can invade organs such as the kidneys, liver, and spleen, leading to serious complications like kidney failure. Because the bone marrow is overtaken, the production of all other blood cells, red blood cells, white blood cells, and platelets becomes suppressed. This leads to anemia, infection risk, and bleeding tendencies. The cause is not fully known. However, research suggests risk factors may include occupational exposures such as agricultural chemicals, benzene, or radiation, as well as genetics and possibly viral triggers. For nurses, it's important to recognize that this disease is progressive and incurable, but treatments can control it and improve quality of life. Pain management, monitoring for anemia and infections, and supporting renal function are crucial parts of care. Signs and symptoms of multiple myeloma. The most common and early symptom is bone pain, especially in the spine, ribs, or pelvis. This occurs because the tumors destroy bone tissue, creating weak spots. Over time, this can lead to pathologic fractures, meaning bones break with little or no trauma. Patients may also have joint swelling and decreased mobility. Other systemic symptoms include fever and malaise, a general sense of weakness and fatigue. This is often related to anemia, immune suppression, or infection. A major complication is spinal cord compression, where bone collapse or tumor growth presses on the spinal cord, leading to severe back pain, numbness, weakness, or even paralysis if not treated quickly. Because bone is constantly being broken down, calcium is released into the bloodstream, leading to hypercalcemia. This can cause confusion, constipation, excessive thirst, and kidney damage. Finally, since the immune system is impaired, patients are highly prone to infections. This is one of the most common causes of death in patients with multiple myeloma. So when caring for these patients, always think about bone integrity, calcium balance, infection risk, and pain management. Diagnostic tests used to identify multiple myeloma. The first step often includes blood tests. A CBC or complete blood count will frequently show anemia and low blood cell counts because bone marrow function is suppressed. We also check serum calcium levels, which are often elevated due to bone destruction releasing calcium into the bloodstream. Next, we use bone imaging, such as X-rays, Connecticut, or MRI. In the X-rays shown on this slide, you can see the bone has a punched-out appearance. These are lesions caused by tumors eroding bone tissue. Another important diagnostic test is a urine test for Bence-Jones proteins. These proteins are fragments of antibodies produced by malignant plasma cells, and their presence in urine is a strong indicator of multiple myeloma. However, not all patients with multiple myeloma have Bence-Jones proteins. Finally, a bone marrow biopsy is performed. This is the gold standard for diagnosis. The biopsy will show an overgrowth of plasma cells in the marrow, confirming multiple myeloma. As LPNs, you won't perform these tests, but it's important to understand their purpose, what results to expect, and how they guide treatment planning. Treatment and nursing care of multiple myeloma. For medical management, the goal is to slow disease progression, control symptoms, and improve quality of life. Steroids and chemotherapy are often the first-line treatments to suppress the abnormal plasma cells. Stem cell transplantation may be considered for eligible patients as it can help restore normal bone marrow function after intensive chemotherapy. Radiation therapy may be used for localized bone pain or spinal cord compression caused by tumors. Another important focus is managing serum calcium levels. Patients with bone destruction are at high risk for hypercalcemia, which can cause confusion, kidney damage, and cardiac arrhythmias. Drugs called bisphosphonates, such as pamidronate or zoledronic acid, help reduce calcium levels and strengthen bones. From a nursing perspective, interventions are focused on safety, mobility, and infection prevention. These patients are at high risk for fractures, bone pain, and immobility. We must protect them from injury by using lift sheets when repositioning, assisting with ambulation and transfers, and encouraging gentle range of motion exercises. The goal is to keep the patient as mobile as possible without increasing fracture risk. We also provide education about preventing infection, maintaining good hygiene, and conserving energy. Because chemotherapy and steroids suppress the immune system, even small infections can be serious. So remember, medical therapy focuses on controlling the disease and calcium levels, while nursing care emphasizes safety, mobility, and infection prevention. Now let's look at Hodgkin lymphoma, a type of cancer that begins in the lymphatic system. The lymph system is part of the immune system and helps the body fight infection. Hodgkin lymphoma is characterized by the presence of a very specific type of abnormal cell called the Reed-Sternberg cell. This cell is usually identified in a biopsy of a lymph node and is what differentiates Hodgkin from non-Hodgkin lymphoma. The exact cause is not fully understood, but there are known contributing factors. Viral infections, such as Epstein-Barr virus, have been associated with the disease. There also appears to be a genetic component, since Hodgkin lymphoma can sometimes run in families. In addition, patients with immune dysfunction, such as those living with HIV or on immunosuppressant drugs after an organ transplant, are at higher risk. This disease is considered one of the more treatable forms of lymphoma, especially if it is diagnosed early. But as nurses, it is important for us to understand its pathophysiology, causes, and risk factors. Signs and symptoms of Hodgkin lymphoma. One of the earliest and most common findings is a painless swollen lymph node, usually in the neck, armpit, or groin. Unlike infections, these lymph nodes are enlarged but not tender. Some patients experience pruritus, which means itching, due to the abnormal immune response and release of inflammatory chemicals. A unique but less common sign is pain in affected lymph nodes after drinking alcohol. Although rare, it is considered a classic symptom. Other systemic signs are related to the body's inflammatory response. These include fever, shortness of breath, night sweats, unexplained weight loss, and overall malaise. Together, fever, night sweats, and weight loss are called B symptoms, and their presence is associated with a more advanced or aggressive form of the disease. As future nurses, it's important to recognize these subtle but critical symptoms because early detection and treatment significantly improve outcomes for patients with Hodgkin lymphoma. As Hodgkin lymphoma progresses, the signs and symptoms become more severe due to the spread of disease. One important late manifestation is edema of the face and neck, often caused by compression of the superior vena cava. This is sometimes called SVC syndrome, and it can lead to swelling, difficulty breathing, and venous congestion. Airway obstruction may occur if enlarged lymph nodes press against the trachea or bronchi. This is a life-threatening complication that requires immediate attention. Jaundice may appear when the liver is affected, either by direct infiltration of lymphoma cells or obstruction of bile ducts. Nerve pain can occur when enlarged lymph nodes press on nerves, and retroperitoneal node involvement may cause abdominal or back pain due to compression of deep structures. When the spleen, liver, or bone marrow become involved, patients may experience organ enlargement, reduced blood cell production, and systemic complications. At this late stage, Hodgkin lymphoma is much more difficult to manage, so early recognition of symptoms and prompt referral are critical in improving outcomes. To confirm Hodgkin lymphoma, the gold standard test is a biopsy. A lymph node biopsy is most common, but biopsies of the liver, spleen, or bone marrow may also be necessary to assess disease spread. The hallmark finding is the Reed-Sternberg cell, which confirms diagnosis. Imaging tests are essential for staging. CT scans of the chest, abdomen, and pelvis can show enlarged lymph nodes and organ involvement. PET scans are very important today because they can detect active disease and monitor treatment response. Other imaging, like chest x-rays, lung scans, and bone scans, may be used to check for organ spread. While these are less common now due to PET-CT, they still demonstrate how staging was traditionally done. Blood tests like the CBC don't diagnose Hodgkin lymphoma, but can reveal secondary effects such as anemia, infection risk, or bone marrow suppression. Overall, accurate diagnosis and staging are crucial because they determine treatment planning, prognosis, and survival outcomes. When we talk about Hodgkin lymphoma, one of the most important factors in determining treatment and prognosis is the stage of the disease. Staging is based on how far the cancer has spread through the lymphatic system and into other organs. Stage I means the disease is localized, only one lymph node region or a single site is affected. Stage 2 means 2 or more lymph node regions are involved, but they are all on the same side of the diaphragm. For example, all in the chest or all in the abdomen. Stage 3 means the disease has crossed the diaphragm. Lymph nodes or organs on both sides are involved, such as both the chest and abdomen. Stage 4 is the most advanced form, where the cancer has spread widely outside the lymph nodes into other organs or tissues, such as the liver, bone marrow, or lungs. As LPNs, your role is not to assign a stage, but to understand what staging means for treatment and prognosis. Patients with early stages often have a better prognosis, while later stages require more aggressive therapies. For Hodgkin lymphoma, treatment usually involves chemotherapy and radiation therapy. These therapies work to destroy the abnormal Reed-Sternberg cells and reduce lymph node swelling. As LPNs, your main role will be in nursing interventions and symptom management. Patients often experience night sweats, so it's important to keep them comfortable by changing linens and gowns promptly to maintain skin integrity and reduce discomfort. Another common symptom is itching or pruritus. This can be very bothersome for patients. Encourage the use of soothing creams or moisturizers, topical corticosteroids as ordered, and oral antihistamines or gabapentin. Remind patients to avoid hot baths, which can worsen itching. In addition, psychosocial support is critical. A cancer diagnosis can bring fear, anxiety, and depression. Be prepared to provide emotional support and connect patients with resources. Finally, because both the disease and its treatments suppress the immune system, monitoring for signs of infection and taking steps to prevent infection is a top nursing priority. Non-Hodgkin lymphoma, or NHL, is a cancer of the lymphatic system. Unlike Hodgkin lymphoma, NHL does not have Reed-Sternberg cells. That's the key diagnostic difference. NHL can arise from B cells or T cells, both of which are important immune cells. The exact cause isn't always clear, but we know several factors increase risk. Viruses such as Epstein-Barr virus, HIV, or HTLV1 are linked with higher rates. Helicobacter pylori, the bacteria known for causing stomach ulcers, can also contribute to the development of certain gastric lymphomas. Other risk factors include immune system dysfunction, such as in patients with HIV/AIDS or those on immunosuppressive drugs, and occupational exposures to chemicals like pesticides or solvents. It's important for you as LPNs to understand the underlying differences between Hodgkin and non-Hodgkin lymphoma because they affect how the disease is diagnosed, treated, and how patients are educated about their illness. Non-Hodgkin lymphoma typically presents with painless, enlarged lymph nodes. This is one of the most common early findings. Unlike infections, these swollen nodes are not tender. Many of the other signs and symptoms overlap with Hodgkin lymphoma. Patients may experience fever, night sweats, unintentional weight loss, fatigue, and itching. The key difference is that non-Hodgkin lymphoma usually progresses more rapidly and can spread to multiple lymph node groups or extranodal sites, such as the gastrointestinal tract, skin, or bone marrow. In the photo, you can see swelling on the left side of the patient's face, caused by enlarged lymph nodes due to NHL. As LPNs, you need to recognize these changes quickly and report them, since earlier intervention leads to better outcomes. When diagnosing non-Hodgkin lymphoma, the most important test is a biopsy. A biopsy of lymph nodes, tonsils, bone marrow, or liver allows doctors to examine cells under a microscope. The key finding is the absence of Reed-Sternberg cells, which distinguishes NHL from Hodgkin lymphoma. In addition to biopsy, imaging studies are used to determine the extent of disease. These include CT scans, MRIs, PET scans, and chest X-rays. A PET scan is especially valuable for staging because it highlights active lymphoma cells throughout the body. Blood work also plays a role. CBCs may show anemia, low platelets, or abnormal white cell counts. Liver function studies and serum calcium can show organ involvement. As LPNs, it is important to understand that these tests help determine the stage of lymphoma and guide treatment decisions, such as whether chemotherapy or radiation will be needed. When treating non-Hodgkin lymphoma, the goal is to eliminate cancer cells and prevent progression. The primary treatment is chemotherapy, often using a combination of drugs such as CHOP, cyclophosphamide, doxorubicin, vincristine, prednisone. Many patients also receive radiation therapy for localized disease. For advanced cases or relapsed disease, stem cell transplants may be considered to restore bone marrow after high-dose chemotherapy. In addition, new options like targeted therapies, such as monoclonal antibodies, for example rituximab, and immunotherapies that boost the body's own immune response, are now standard parts of treatment. As nurses, your role is very similar to caring for patients with Hodgkin lymphoma. This includes monitoring for infection because chemotherapy and radiation weaken the immune system. You will help manage side effects such as nausea, fatigue, and hair loss. You'll also provide psychosocial support for patients coping with a cancer diagnosis. Remember, patients with lymphoma are at high risk of infection, so good hand hygiene and teaching the patient how to prevent exposure are critical. When comparing Hodgkin lymphoma and non-Hodgkin lymphoma, it's important to focus on key differences. Hodgkin lymphoma is less common and has a bimodal age distribution. It peaks in young adults in their 20s to 30s, and again after age 55. It is characterized by the presence of Reed-Sternberg cells, which are abnormal large lymphocytes seen under the microscope. Patients tend to be younger, and the disease usually responds very well to treatment, so the prognosis is generally good. A unique feature is that some patients experience pain in lymph nodes after drinking alcohol, which can help with diagnosis. Non-Hodgkin lymphoma, on the other hand, is more common and usually affects people over age 60. It does not have Reed-Sternberg cells. There are many subtypes, and it tends to be more aggressive in many cases, meaning the prognosis can be poorer compared to Hodgkin. Non-Hodgkin often progresses more rapidly, but modern therapies like targeted monoclonal antibodies and immunotherapy have improved survival. As nurses, when you care for these patients, remember both groups require close monitoring for infection, fatigue, and psychosocial support, since the treatments, chemotherapy, radiation, or stem cell transplant, are very similar. Now let's talk about splenectomy, which is the surgical removal of the spleen. The spleen plays a major role in filtering blood, fighting infection, and storing platelets. When it becomes damaged, enlarged, or is contributing to disease, removal may be necessary. Splenectomy can be partial, where only part of the spleen is removed, or total, where the entire spleen is taken out. This surgery may be done as an open procedure with a larger abdominal incision, or more commonly today as a laparoscopic procedure, which uses small incisions and a camera. Laparoscopic splenectomy often allows for shorter recovery times and less pain. For LPNs, it is important to know that removing the spleen significantly increases a patient's risk for infection, especially from encapsulated bacteria like pneumococcus, meningococcus, and Haemophilus influenzae. That means these patients need vaccinations before surgery if possible and lifelong infection precautions. Postoperatively, nursing care includes monitoring for bleeding, infection, and signs of impaired immunity. Teaching patients about the importance of seeking care promptly for fevers or signs of infection is crucial since they no longer have the spleen's immune protection. Nursing care for patients undergoing splenectomy. Preoperative care starts with getting baseline labs and vital signs. This helps us compare post-op values to identify complications early. Sometimes, because the spleen is highly vascular, the patient may need a blood transfusion before surgery. Giving vitamin K may also be ordered to improve clotting and reduce the risk of excessive bleeding. Another important pre-op step is to teach the patient how to cough and take deep breaths effectively, since splenectomy is an abdominal surgery and patients may be reluctant to breathe deeply due to pain. Practicing beforehand helps prevent complications like pneumonia or atelectasis. Post-operative care is focused on safety and recovery. First, we need to monitor closely for bleeding because the spleen is very vascular and hemorrhage is a major risk. We continue to monitor vital signs to watch for early changes that might suggest bleeding or infection. Pain control is essential, often with prescribed narcotics. When pain is managed, patients can perform coughing and deep breathing exercises more effectively, which helps expand the lungs and prevent pneumonia. Finally, we need to encourage ambulation, because early movement promotes circulation, reduces the risk of blood clots, and speeds recovery. As LPNs, always remember that splenectomy patients are also at an increased lifelong risk of infection. They will need education on vaccinations and infection prevention before discharge. Complications of splenectomy. The first risk is bleeding. Remember, the spleen is very vascular, so hemorrhage is one of the most serious post-op concerns. This is why vital sign monitoring and surgical site checks are so critical. Another complication is pneumonia and atelectasis, which is the collapse of part of the lung due to shallow breathing or mucus plugging. Patients may avoid deep breaths because of pain, so our teaching about coughing, deep breathing, and incentive spirometry becomes essential. Infection is also a significant concern. Without a spleen, the body loses part of its ability to fight bacteria, especially encapsulated organisms like Streptococcus pneumoniae and Haemophilus influenzae. The most severe complication is something called overwhelming post-splenectomy infection, or OPSI. This is a rare but life-threatening condition that can develop very rapidly, even years after the spleen has been removed. Patients must be educated to seek immediate care if they develop a fever, and they will need lifelong vaccinations and infection prevention measures. As LPNs, your role is to recognize early warning signs, changes in vital signs, respiratory difficulty, unusual bleeding, or fever, and report them immediately. This is critical for keeping patients safe after a splenectomy. This concludes the presentation. Thank you.